Here are my disclosures. This presentation was made at Indian Arthroscopy Society Conference, Jaipur, October 13th. Pictures and videos were taken from the respective articles and ViewMedi. I was asked to talk on ACL anatomy and the current concept of ACL reconstruction. Respected Chairman, colleagues, ladies and gentlemen, I bring lots of greetings from Nepal and our society. Thank you organizers for having me here. It is really an honor for me. I and many of us grew up as ACL surgeon watching this video from Freddy Fu and his group. This video nicely demonstrates two bundles of ACL and their different functions. Recently, Dr. Robert and his colleague came up with the newer concept of ACL, the ribbon concept. This concept has been viral in my country, and wherever I go and talk about ACL, this question is raised and asked. This may be the reason why the ACL anatomy talk was kept to start the ACL session here. When I first came to know about the title, I felt I was made scapegoat. Believe me, talking about anatomy in front of Dr. Freddy Fu is not easy. When I requested my friend Bikram to change my topic, he said, if not, who else is going to do this? I felt that I am in trouble. My trouble multiplied when I started doing literature search and found that there are controversies all around. There are controversies in number of bundles. Some even says ACL is not in bundles, it is a flat ribbon. There are controversies in location of footprints. Either it is high, it is low, it is at the center, or it is eccentric. And there are controversies in size and shape of the notch. On top of that, all these things have to be covered in 10 minutes, almost a mission impossible. To make my life easy, I decided to take this controversial issue one by one. The first issue I'd like to discuss here is about bundle and the ribbon. If you go to literature and try to clarify the bundles of ACL, you will find three groups of literature. One group saying ACL is a single bundle structure. There are no distinct separate anatomical bundles. However, they agree to the fact that there may be many functional bundles. The other group describes ACL as two bundle structures, each bundle having their own specific functions. There is a third group describing ACL as a triple bundle structure. Similarly, the ACL surgeons were also grouped into three groups: the single bundle surgeons, the double bundle surgeons, and there are surgeons reconstructing three bundles of ACL with very good results. So whatsoever, how many bundles there may be, we were comfortable with reconstructing ACL in bundles. All of a sudden, there was a twist in anatomy of ACL. Roberts and his colleague introduced a ribbon concept of ACL. Now there is a fourth group of surgeons thinking of reproducing the ribbon anatomy of the ACL. The ribbon group says that the ACL is flat in its mid-substance, it has a C-shaped tibial attachment and have direct and indirect fibers in the femur. However, if you carefully read their article, you will find the description of bundle effect of the ribbon-shaped ACL. I personally a big fan of Dr. Freddy Fu and his research. His compartment concept feels more appealing for me. He has proved histologically and biomechanically the septum creating the bundles. So it is the septum which divides ACL into AM and the PL bundle. If we remove the septum, the bundle structure is lost. If you carefully compare the video of Dr. Fu and Dr. Roberts down here, you will find lots of similarity in the ACL. I presume it is just a perception of the surgeons is different. ACL still remains the same. There is no point in being squeezed between ribbon and the bundle concept. What is important for me as a clinician is the functional anatomy and the functional outcome. We want to reconstruct a functional ACL, not a static ACL. And ribbon in function has bundle effect. So for me, at this moment, the bundle concept of reconstruction attracts more than the ribbon concept of reconstruction. The second issue I want to raise here is about footprint location. Till recent past, we were all around the condyle to achieve the exact anatomic location. We were very high when we were doing transtibial ACL. Then we came low and posterior, and we thought that we are anatomical and believed that this location is good enough to replicate anatomic ACL reconstruction. One of the recently published articles from Swedish registry mentioned that there is significant number of revision rates in case of anatomic ACL reconstruction when it is compared with non-anatomic ACL reconstruction. By saying non-anatomic, they meant a transtibial ACL reconstruction. Non-isometric location and increased force at anatomic ACL was said to be the cause of more failures. This gave birth of a new concept which is known as ideal concept of femoral footprint. Ideal is a mnemonics which stands for isometric, so the ACL is isometric. It reconstructs the direct fibers. It is eccentric into the footprint yet anatomic. So it is into the footprint but not at the center of the footprint, but it is eccentric. Even if it is eccentric, it is within the footprint, that is why it is anatomic and have low tension. So the chances of failure is less. This ideal concept looks promising, but still have to wait for the long-term outcome. The third issue is the notch anatomy. In a very interesting study by Saeed and his colleague, they describe three types of notch. In their study population of ACL tear, 73% had type A notch. Probably, notchplasty will have some role in this type of narrow notch. To take this further, I'd like to quote an article from Fu and his group who described variation in dimension of notch, both in its height and width. They also mention about various sizes and shape of both tibial as well as femoral footprints. From various literature, there is enough evidence to say that there are subtle variation in anatomy from person to person. So the anatomic ACL reconstruction must vary from person to person. This gave birth to a relatively newer concept which is known as the individualized concept of Dr. Freddy Fu. We all are different. Our knees must be different. so our need is also different. So probably we are entering into the new era which is known as the individualized approach. Look at the anatomy and note the difference. Thank you very much.